This video covers choledocolithiasis, and so let's begin. So choledocolithiasis is a stone that is lodged in the common bile duct, resulting in blockage of the bile acids flow, and this the stone, when it is lodged in the common bile duct, it results in dilation of the common bile duct. Okay, and also backup of bile acids, and this can result in a secondary bacterial infection. Okay, so choledocolithiasis, what is the diagnostic criteria? Okay, the hallmark is elevated alkaline phosphatase and high total and direct bilirubin. This is expected when you have a stone lodged in the common bile duct. Then the bile acids, bilirubin, starts building up. It results in dilation of the common bile duct and elevation of these acids. Okay, so on imaging, usually an ultrasound will show a dilated common bile duct. So if you have this, the diagnosis for choledocolithiasis is made. Okay, so how do you what's the best initial diagnostic testing? You always do a right upper quadrant ultrasound. Okay, that's the best initial imaging, which may show a gallstone with possible sludge or biliary dilation. Now, before I go in detail of all the other diagnostic testing, it is important to know the risk stratification associated with choledocolithiasis. This is according to the American Gastro Society. So it states classifies choledocolithiasis into high risk, intermediate risk, and low risk. So high risk patients are ones who have common bile duct stone on ultrasound. Okay, you see this is an ultrasound, and that is the common bile duct. So a dilated common bile duct and a lodged stone in the common bile duct. So number one, a common bile duct stone on ultrasound. Number two, clinical ascending cholangitis. So ascending cholangitis is usually a Charcot's triad. It presents with jaundice, fever, and right upper quadrant pain. So if there is any clinical significance for ascending cholangitis, or there is severely elevated bilirubin, more than 4 mg per dl, patient is jaundiced, then these patients are high risk group and immediate ERCP is indicated. Okay, so pictures are always good memory aid. So remember high risk patients who present with a common bile duct stone on ultrasound, any patient who has signs and symptoms of acute cholangitis and elevated bilirubin more than 4 mg per dl, these patients need an ERCP because they fall in a high risk group. The next group is intermediate risk group who needs MRCP or endoscopic ultrasound. Who are these people? Now, patients who present with a dilated common bile duct, okay, dilated common bile duct on ultrasound, okay, patients who are more than 55 years of age, okay, older patients, abnormal liver function tests, and a gallstone pancreatitis, okay. So these patients will need fall under intermediate risk and will need an MRCP or endoscopic ultrasound. Okay, then the other group is the low risk group who eventually will need cholecystectomy. These patients have no symptoms suggestive of choledocolithiasis and no other definitive findings. These patients eventually will need cholecystectomy. Okay, so that is the risk stratification associated with choledocolithiasis. Now, going to the diagnostic test again. When do you do an MRCP? This is highly sensitive for common bile duct stones, and it is indicated in patients with intermediate risk of choledocolithiasis. Okay, When you do an EUS or endoscopic ultrasound, again, it can be done interchangeably with MRCP. Okay, so if there is still suspicion for choledocolithiasis, even after cholecystectomy with abnormal lab findings, patients with intermediate risk of choledocolithiasis can undergo EUS or MRCP. Then ERCP is indicated in patients who have high risk of choledocolithiasis. It's because it's both diagnostic and therapeutic. ERCP is preferred in patients who are at high risk. High risk are patients with common bile duct stones on ultrasound, acute cholangitis, and high bilirubin level. Now, as I said earlier, the studies involved in choledocolithiasis because of backup of the acids. There will be increase in alkaline phosphatase, increased GGT, increased total and direct bilirubin, mild elevation in liver enzymes, and sometimes infection can happen, and that results in increased white blood cell count. And those are the labs associated with choledocolithiasis. So how are you going to treat choledocolithiasis? Management approach is removal of the common bile duct stone, right? So you do an ERCP, often with sphincterectomy, okay? So indication of ERCP is choledocolithiasis with acute cholangitis not responsive to medical treatment, gallstone pancreatitis, diagnostic and therapeutic. ERCP is both diagnostic and therapeutic, therefore it is indicated in patients with choledocolithiasis, okay? And the adverse effect of ERCP is pancreatitis and cholangitis. And laparoscopic cholecystectomy, after an ERCP, within 72 hours, you need to do a laparoscopic cholecystectomy as well. Okay, and sometimes patients who are not good candidate of treatment, you may start ursodeoxycholic acid. And also, it is a prophylaxis for gallstones are uncleared from the common bile duct, so that it can be used as a prophylaxis as well. Complications of choledocolithiasis is gallstone ileus, gallstone pancreatitis, and hepatic abscess. And so let's now start solve a question from UWorld. So we have a patient who comes to the emergency department. Okay, he returns from to the emergency department 6 months later with recurrent, persistent abdominal pain that has waxed and waned for the past 30 hours. Now, she has also nausea and episodes of vomiting. No temperature is normal, vitals normal. She had mild ectris. Okay, the abdomen is tender in the right upper quadrant without guarding or rebound. So they have right upper quadrant tenderness, nausea and vomiting, and lab shows 12,500 of leukocytes. Creatinine is normal, AST mildly elevated, alkaline phosphatase is elevated with high, total bilirubin is 2.5, lipase is normal. Abdominal ultrasound shows mildly distended gallbladder with multiple stones, no pericholecystic fluid, and large common bile duct of 1.1 centimeter. Which of the following is the best next step in the management of this patient? Okay, now this patient is a high-risk patient. Why? Because this patient has dilated common bile duct on the ultrasound. Okay, and signs of infection, cholangitis, okay, or what are the other indications for high risk? As we said, high bilirubin level, okay. So here, the ultimate next step for any patient who presents with choledocolithiasis would be an ERCP, okay. So because it's both therapeutic and diagnostic, okay. So this patient, prolonged abdominal pain and jaundice with liver function test abnormalities and a dilated common bile duct likely has choledocolithiasis, okay? So patients commonly have typical biliary colic symptoms. Unlike choledocolithiasis, CBD stones cause accompanying biliary outflow obstruction. So it shows a cholestatic liver function abnormalities with elevated bilirubin, alkaline phosphatase, out of proportion to aminotransferase, and more prolonged pain. Okay, Now, choledocolithiasis is diagnosed by visualization of the stone within the common bile duct. However, ultrasound is insensitive for detecting distal stones. Therefore, an ERCP allows for both diagnostic and therapeutic removal of the stones and is the best next step. Who do we do ERCP? Patients who are at high risk. Visualize choledocolithiasis, high risk features like dilated common bile duct on ultrasound, elevated total bilirubin, and evidence of acute cholangitis, fever, right upper quadrant pain, jaundice, hypotension, confusion. These patients also require IV antibiotics and treatment of sepsis. So in patients in whom choledocolithiasis is suspected, who have none of the above criteria, a less invasive procedure like MRCP should be considered. Okay, so like how we said, it all depends on the risk stratification. Any patient who have any of these high risk features will go for ERCP. Intermediate risk patients may go for MRCP. Okay, so after ERCP, laparoscopic cholecystectomy is performed on a non-emergent basis to prevent further complications. This is what we have told, right? So when you do an ERCP, within 72 hours, you go for a laparoscopic cholecystectomy. Why? Because we want to prevent recurrence, okay? Intraoperative, during cholecystectomy, CBD stone removal is occasionally performed. It is technically challenging and rarely undertaken in the era of ERCP. Okay, so we don't do that anymore. Immediate cholecystectomy is usually reserved for patients with emergent indications, for example, shock, perforation, or who are at low risk of surgery. Okay, so this is all about choledocolithiasis. Hope that is helpful, and please do subscribe to my channel and hit the like button. Thank you so much.